Life-threatening conditions which are connected with airways are as follows. So when you should think that there is a problem with airways, you should think about it when the airways are obstructed. So if you do not hear any breathing, or you hear some snoring or wheezing from the airways or stridor, when it might happen. So generally, of course, in cardiac arrest or traumatic cardiac arrest, the airways are closed and they should be opened to be able to ventilate the patient. When there is no traumatic cardiac arrest, all patients with Glasgow Coma Scale below or equal 8 should have their airways secured. There is some acronym in intubate on 8 connected with this with the GCS. In AVP U scale, the GCS 8 will be equal to patient who reacts only to pain. So in such situations, you should always think to secure the airways of the patient, because the patient is in danger of aspiration of the stomach content or closure of the airways. So when you might have the patient with GCS below 8, in head trauma, the patient with respiratory failure due to hypoxia of the brain, or among the patients who are in shock due to hypoperfusion of brain, which provokes the decreased level of consciousness. Always be aware of some problems that might come in patients, among patients with craniofacial trauma, because the edema might build up, edema of the upper airways or edema of the face, which might provoke the obstruction of the upper airways. And be very careful with the patients after burns, especially those who have been inside the room or place where there was very hot air, because they are at much risk of burning injury of the upper airways. And at the beginning, that they might seem, let's say, okay, but they might be conscious, they might be in contact. But in case of any signs of burning of the upper airways, such as redness of the tongue, or signs of burns inside the mouth, or change of the voice into the coarse voice, for example, you should anticipate the edema of the upper airways and sedate the patient, give the painkiller drug, and secure the airways with the tracheal tube in such situations. How can you secure the airways patency? So at the beginning, if you arrive to a trauma patient who is, let's say, breathing, but there is some snoring sound suggesting some obstruction of the airways, you can use the jaw thrust maneuver. So holding the chest, pushing the jaw upwards. It's called S-mark maneuver. This maneuver do not provoke any movement of the cervical spinal cord, so it's safe for the trauma patient. But when you arrive with the ambulance or you're in the hospital, you've got equipment. So the basic equipment to secure the airways are the oropharyngeal tubes and nasopharyngeal tubes. But those tubes only, let's say, open the airways, but they do not secure the lungs of the patient from some aspiration of the stomach content, for example. So the easiest way and the most effective way to secure the airways is to use the supraglottic devices. So for example, igel, laryngeal tube, laryngeal mask. Those devices are inserted blindly, so you do not have to be an anesthesiologist or emergency physician to be able to secure the airways using those supraglottic tubes. They prevent, let's say, almost 100% from aspiration of the stomach content. And to insert them, you do not have to, let's say, take out the cervical collar or move the neck in trauma patient. If you're an expert, you would probably intubate the patient, so put a plastic tube through the vocal cords into the trachea. Let's say that's the best way if the patient will end up in the intensive care unit, for example, for the prolonged time. But actually, let's say in the first stage of taking care of the patient, the supraglottic tubes are enough in most of the patients, except, let's say, burning injury patient, because the edema is at the level of vocal cords and supraglottic tube lies just over the vocal cords. So in such patients, you would need to put the plastic tube in between the vocal cords, so you would use the intubation tube. In case of huge trauma, huge edema of the upper airways, when you cannot ventilate the patient through bag and mask, you cannot intubate the patient, you cannot put, let's say, supraglottic device, and no ventilation is possible, the final thing to do is the cricothyroidotomy. The best way is to perform the surgical cricothyroidotomy using the scalpel, bougie stylet, and intubation tube number 6. But if you're not able to do it, let's say the needle cricothyroidotomy might be the option. Remember that securing the airways of the trauma patient might be difficult, and you should treat the airways of the trauma patient as a difficult airways. So it's good to be prepared for it, properly prepared. And there's an algorithm called speed bump, which states for pre-intubation checklist, and each letter is very important. And while you prepare the equipment for the intubation, or one of your team members prepares this, let's say, intubation or securing the airway kit, they should go through the list. So first, S means suction. So the suction device should be ready and checked, because when you secure the airway, sometimes you have to suck the blood, some vomits from the upper airways, just to make the, let's say, intubation more smooth, more, let's say, just to make better visibility. Then the positioning is very important. The patient should be in the supine position. If you would like to intubate the patient, then you have to open the cervical collar, and someone from your team should manually stabilize the neck from the front. So position of the body is important. Then equipment for intubation, but equipment for securing the airways. So at least, let's say, 2 laryngoscopes, 2 blades of laryngoscope, or even 3, like small, medium, large. The bougie stylet, bougie guide, 2 tubes with different sizes, and the syringe to inflate the cuff of the tube. Then another E is end-tidal CO2. So the gold standard confirmation of the proper secured airways and efficient ventilation is checking the end-tidal CO2 on the monitor. So if you can see the wave of end-tidal CO2, then you are sure that the air goes into the lungs, not into the stomach. Of course, you should always, after putting the tube, auscultate the lungs. If you can, first of all, auscultate the epigastrium to exclude intubation of the esophagus, and then auscultate the lungs on both sides to check if there are symmetrical, if there's symmetrical air entry. Then D stays for the drugs and IV or IO access. So at least 2 IV accesses should be inserted into the veins of the patient, and you should have the drugs prepared. So the painkiller drugs, usually we use fentanyl, then sedation drug, or ketamine or etomidate. Usually those 2 drugs we use. Propofol decreases the blood pressure, so usually in trauma patient we omit this drug. And then the drug to myorelaxant drug like rocuronium or succinylmetonium. So those drugs have to be prepared. Then B states for backup devices. Okay, so you should have some kind of backup. So if intubation will fail, you should have supraglottic device ready, and also cricothyroidotomy kit should be ready. Because after giving the drugs, then there is not much time to secure the airways. You should always have with you self-inflating bag with the mask, because if securing the airways fails, saturation drops, you should oxygenate the patient using the bag and mask ventilation. Then O states for oxygen, pre-oxygenation of the patient. M for monitoring, so the minimum monitoring is the heart rate, blood pressure, saturation, and end-tidal CO2. That's the minimum you should be prepared for. And then B stays for briefing. So you should perform the briefing to your team before securing the airways. So everybody has to know what to do. Who is manually securing the neck? Who will give the drugs? Who will perform the intubation? Who will provide the bougie stylet, who will provide the intubation tube. So when it comes to airways, if you hesitate if the patient is for intubation or not, intubate. You can always extubate the patient. So be very cautious about the airways if they are patent and if they are at any danger of obstruction.